So, excuse my voice. Savannah's starting to get to our health. She has this new thing where she likes to do dentist, where she just goes, ah, and then she puts her finger in your mouth. And it's really cute, but obviously it's starting to have a detriment on my health. So, I feel fine. My voice is just a little gone today. So I hope everybody online can hear me still. All right, so today we are going to be starting our unit on,
I have a question before we begin about the test, a couple of questions on the test.
Okay.
So for me it was question 22 and 23. 22 was high amplitude phase encoding steps, edges of K-space are weighted more to, and the options were spatial resolution or image contrast and SNR. So on that one, I put image contrast and SNR because I'm under the impression that the high amplitude phase encoding steps are in the middle.
Yeah.
Thus, it's contrast and signal, and then the outer is for spatial resolution and low amplitude. But it marked both of those incorrect.
Yeah, I was looking at the wording on that, and what that mock registry question I pulled from, I think they mean high amplitude of how steep the gradient was. So it's like a steeper gradient, phase encoding gradient, is going to fill the outer lines of case.
I was thinking, like, from the notes I took, I had high amplitude was right area.
Yeah.
And,
I'll take a look at those questions because, I don't think the last class really hit, but I think you guys are digging a little deeper into it and that's good because you're right in that if you look at the signal, the amplitude of the signal is higher in the middle of K-space. But that question was trying to ask higher amplitude as in putting more current into that gradient coil, and that applied a steeper gradient, and then that's the outer.
I get it now. Because it says high amplitude, but then it says edges of K-space.
Yeah.
Wait a minute.
No, but great question.
Okay.
And I'll take that into consideration for sure.
Thank you.
All right, so today we are moving on to parameters and trade-offs. So in MRI, we have the luxury of manipulating our parameters. And what parameters are those that we can manipulate? Intrinsic or extrinsic? Extrinsic. And why do you think the chapter is also named trade-offs? Why do you think it's also named trade-offs?
change. You can do one thing instead of something else.
Yeah, and sometimes when you do one thing to maybe increase your signal, you have a negative trade-off in that you are losing a little bit of resolution. So in MRI, you're constantly balancing. So I created a kind of a PDF that's a quick snapshot of the chapter. But the first thing we're going to talk about is that balance. And the main things you're balancing at all times in MRI is your signal-to-noise resolution, SNR, your scan time, and your spatial resolution. Because those three things are going to be a big factor when we're talking about image quality. Because for MRI, we want the greatest image quality, right? Just like in X-ray or CT, we want the best image for the radiologist to read. But we know that's not always possible, depending on the patient's, their body habitus, or even if they're not able to hold still throughout the entire scan due to being like claustrophobic or just in pain. So we have to constantly balance these things, and we have to take into consideration factors, and the main factor being the patient. All right. All right, so in MRI and on our MR console, we have many of these extrinsic parameters available to us to manipulate. A protocol or a pull sequence is really just a set of rules, depending on where you set your TR, how you set your TE. That will determine image weighting, and then some other extrinsic parameters like next, that will boost our signal. And then you have your geometric parameters. What do you think the geometric parameters are? Give me some examples of those.
Matrix size.
Matrix size, so good. Both in the phase and the frequency. What's that? FOV, field of view. There's one more. And remember, we're thinking about 3 dimensions for MRI. Huh? So voxels, what's the other dimension? We have phase, frequency, and slice what? Selection. Thickness.
Yeah.
Good. So when we're talking about geometric parameters, let's write this down here. The 3 main things that are going to affect spatial resolution are your field of view, your matrix, and that could be your frequency encoding and your phase encoding, and then slice thickness. Because once again, we are always thinking in the 3-dimensional mindset in MRI. Okay. And then we have a bunch of other imaging options, and we'll cover that today and in the subsequent chapters. Everybody got this written down?
Not yet.
Okay, take your time. So while she's writing that down, what are some extrinsic parameters that you think will affect signal? TR?
T.
TE, good. What else?
Next.
Great, next. What's the other acronym for next?
NSA.
NSA. Does anybody remember what those stand for? Good. And what's NSA? If you had to guess. Number of signal averages. So if we fill that row of K-space twice, we're going to average the signals within that row. That's what that means. Anything else?
Turbo?
FOV.
I guess you could
Oh,
say
extrinsic. Ish.
the turbo factor or the echo train length, but
Flip angle.
flip angle's a better option.
Like dial tone. Viewing time.
Right.
I'll actually have to think about the echo train length, because what it does is it fills more lines of K-space, so it's really dealing with your scan time, but it's not going to increase your signal per se.
Oh.
So it'll allow you to scan faster. NSA, another one would actually be receiver bandwidth. So when we're talking about receiver bandwidth, is this when we're applying an RF pulse to determine a slice thickness, or is this when we're collecting the signal at TE?
Collecting the
Good, we're receiving that signal. And we'll talk about how, if we have a broad versus narrow, how we can filter out some of that noise. Anything else you think? I think this is a good start. It's a good start. So write this down. Give you another second here. So once again, extrinsic parameters, things we can manipulate on our console. Geometric properties, another thing we can manipulate on our console, but they're really going to be dealing with spatial resolution compared to signal. All right, let's move on. All right, so it is our duty to optimize the protocols. And protocol optimization enables us to maximize image quality and acquire those diagnostic images that the radiologists love in the shortest scan time. So I've changed up the slides a little.
Oh,
that's a lot.
yeah.
So these are some skills that are a major part of our clinical practice. So as an MRI technologist, this is where we can really shine. If we're able to get the best image quality for a patient that's, say, in a lot of pain and can't hold still for very long, our radiologists are going to really enjoy seeing those images come across from say Rachel or Nick, and they start to trust you a little bit more, and they know you're going to do your best, even considering if you have a very hard patient. These protocols are judged by how well they show anatomy and pathology. So what sequence usually shows anatomy? What type of weighting? What type of weighting shows pathology? Okay. Now, why do you think anatomy is visualized better on T1? Why is that? What parameter is always associated with T1? What parameter? TR. Okay. So if you have a longer TR, you're allowing that tissue to relax, recover back to full recovery, and then you have more of that net magnetic vector to flip into that transverse plane during the next RF pulse. So if you have a longer TR, usually you get better signal, which you can see the anatomy better from. But then when we're talking about pathology, we're really concerned more with contrast to noise resolution, because our water is bright on our T2 weighted images due to it relaxing a lot slower and decaying a lot slower. But T2 is not so great at showing anatomy because our signal's a lot lower. Even though our contrast to noise resolution looks better, our signal is actually going down. So, and what's our parameter that controls T2? It's like the Jeopardy. You're answering the question before I had a time to ask the entire question. That's fine. So with TE, remember, if you have a long TE, that signal's decaying a lot. So if you have a long TE, you have less signal. So it's not really an ideal weighting for visualizing anatomy. You don't have much signal. So pathology, because contrast to noise ratio. T1 for anatomy, because higher signal. Okay. So our protocols, once again, are judged by how well they show anatomy and pathology, and this is based on producing images that demonstrate the following 4 characteristics. So we're constantly balancing between these 4 things. So we got signal to noise ratio, and ideally we would want that very high. Contrast to noise ratio, and we can't really say high or low because it's nothing you can measure. It's just something your eye observes. So you would just want good contrast to noise ratio. You can't have high, low contrast to noise ratio. And spatial resolution, you would want high spatial resolution. So would you want a smaller or a larger pixel or voxel? Smaller voxel. Good. So high means smaller voxel. And then scan time. We want scan time to be as low as possible. And once again, what is our scan time equation?
Phase encoding steps times next times
TR. Almost. TR times number of phase encoding steps times next. And that's for a 2-dimensional pulse sequence. And we'll talk about how we calculate it for a fast spin echo and a 3-dimensional sequence. And that's, if you see those questions, that's kind of how we're going to start answering those questions. But like I said earlier in the lecture, we're constantly balancing these things. So if we optimize parameters in favor of one of these characteristics, usually that means we're going to have to compromise for another. The skill on our part lies in making informed decisions about which is the most important characteristic. Or do we desire high signal? Or do we desire high resolution for this type of scan? Where's resolution a little bit more of an importance? What do you think? Pathology, but what, I guess, section of the body would you say? MSK, good. Where is it really important to get really high contrast to noise rate? Vascular and pathology, yeah, because you want to be able to see that pathology pop out. And that's why we usually fat sat post-contrast, because we're just trying to null out all that fat so we can see that tumor even easier. Okay, so let's break down signal-to-noise ratio. We keep hearing this term, but what does it really mean? So signal-to-noise it's a ratio of the amplitude of signal received by a receiver coil in that transverse axis. And that's going to be a ratio to the average amplitude of the noise. So our signal is the voltage induced in the receiver coil by the precession of that net magnetic vector in the transverse plane. So we've understood this concept by the last couple of units. So we have our net magnetic vector gets flipped into the transverse axis, which is 90 degrees from our longitudinal axis. It basically precesses around that axis, and every time it comes in proximity to that receiver coil, it induces a voltage by Faraday's law of induction. So we've talked about this. So that's how our signal's created. The one thing we really haven't talked about is noise. And noise is really just the frequencies that exist randomly in space and time. These are things we cannot control. So noise, since this is the newer concept, we receive noise in two ways. It's generated by the presence of the patient within the scanner and by background electrical noise of the system. So remember, we do a lot of things to try to eliminate noise, but sometimes we can't eliminate it completely. So like we have the Faraday cage to eliminate random RF pulses coming into the room. Remember, Faraday cage is created out of what?
Copper.
Copper. Good. So that's a way to reduce it. But sometimes those outside frequencies are already contained within our room, and we can't control them from being part of our signal-to-noise ratio. Noise is constant for every patient. Depends on the build of the patient. So if you have an ascenic patient or a hypersonic patient, you might have more or less noise. And you can't really say that a hypersonic patient, just because they have more tissues, is going to create more noise. So it really just depends on every patient and kind of what they're composed of. Where if a patient has a hip replacement, they have metal within that hip, it's going to create an artifact on our image. That's more noise. So different factors depending on the patient. The area under examination. So when we're scanning, say, the brain versus like your neck, sometimes you get artifacts and noise associated with those air tissue interfaces, especially on that diffusion scan. Remember I showed you guys that diffusion scan? And it's not a very high signal pulse sequence. So when you scan through the brain, and once you get to those slices that where you have the orbits and the brain within the same slice, it creates that high signal. That's what we call an air tissue artifact. So it depends on the area under examination. And then your scanner itself just has an inherent noise within the system. And we try and do the best job by, we have our shimming coils to kind of reduce the amount of parts per million, which is our unit for homogeneity. Remember, we want it to be less than 4 parts per million before we even start using our scanner. We want it to be as homogeneous as possible to reduce the amount of noise and certain types of artifacts. So you're starting to see me relate noise to almost like artifacts, right? These are things we want to, either eliminate or increase our signal so much that we don't even have to worry about our noise. Because remember, noise is going to be is part of every image. We just need to increase our signal to reduce seeing the amount of noise. So noise is random. Signal is cumulative, and it occurs at TE. So our readout gradient, which is also called our frequency gradient, is turned on when we are receiving our signal. Signal is dependent on many factors, like those intrinsic parameters. But sometimes there are some parameters that we really can't control. I'll talk about those. And signal can be altered. So if we change our next, what happens to signal? We'll talk about that today. So signals therefore increase or decrease relative to noise. The only time we're able to really eliminate noise is narrowing our receiver bandwidth. So that's kind of the only exception where we're able to kind of eliminate noise. In other regards, sometimes we're averaging out the noise. That's our next. But most of the time, we're really just increasing our signal, and our noise stays constant.
So narrow RPW.
Exactly. A narrow RV, it filters out the noise. Yeah. But the noise is there, it's just
Still there.
we're using a narrower filter, so we're filtering out.
We are currently experiencing issues logging into DDP and
So here are those factors that influence SNR. Man, we're getting a lot of interruptions.
Noise.
Oh, yeah, we got noise. We got to filter that out. We got to close that door. How about that? All right. So here are the factors that influence SNR. We have our magnetic field strength. So obviously, a 1.5 Tesla is not going to create as much signal as our 3 Tesla magnet. Proton density, is that an intrinsic or extrinsic parameter? Can we manipulate it?
Intrinsic.
Intrinsic. Remember, proton density is an intrinsic along with T1 recovery and T2 decay. Those are things we cannot change. What about magnetic field strength? Can we change that? You can decide what scanner you want your patient to go on, right?
Right.
So if you do happen to have a 1.5 Tesla and a 3 Tesla within your department, obviously you would want to choose the 3 Tesla for certain scans like breast imaging, prostate imaging, things where we know we really need small voxels or better spatial resolution. So we need to have a higher inherent signal for those type of scans.
So say when they order a scan like that, they do the ordering physician know that, for example, they're going to send them to a place where they have.
Yeah, I mean, so for breast imaging, the ACR guidelines, they have to be at a 1.5 Tesla or above.
Oh, okay.
So if you do have a 3 Tesla, that's a luxury, but you do have to actually scan certain bodies or areas of the body under certain magnetic field strengths. So you have prostates and breast imaging, usually 1.5 and above. But if they did send them accidentally to like an open scanner or like a permanent or resistive type magnet, the technologist should be aware that they shouldn't be scanning that patient anyway. And typically they're not going to have a breast coil for those type of machines anyway. So you're only really going to get breast coils that are specific to 1.5 and greater Tesla magnets. But yeah, great question. Voxel volume. So as our voxel volume increases, obviously our spatial resolution goes down, but our signal goes up because we're able to get more of those hydrogen spins within that voxel. Our TR, TE, flip angle, next, receiver bandwidth, coil type. We talked about a couple different coils. So if we had a linear coil versus a quadrature coil, which one's going to give us more signal? Good, because we have 2 coils that are 90 degrees from each other that are going to create 2 RF pulses, and that's going to increase our signal by 40%. And then pole sequence selection. And that's really because pole sequence is always really associated with TR and TE, so this kind of goes with these two. All right. So I would say this probably plays the most important role, but we cannot actually manipulate this, our magnetic field strength. We just kind of have to work with what we have. So if we go and we're working at the main hospital here, we have 2 3 Tesla magnets, and then we have a 1.5 Tesla magnet. If you happen to, if your first job is at an outpatient facility that's an open MRI scanner, you just really have to work with what you got. You know you're going to have less inherent signal, so you're going to have to sometimes increase our next, increase our TR, manipulate those factors to get better signal. So this is really just, it depends on your facility that you're working at, but remember when we talked about increasing our field strength, how it makes those spins that usually are not able to oppose that static magnetic field strength align with that static magnetic field. So as we increase our field strength from 1.5 to 3 Tesla, you could say the energy gap between those high and low energy nuclei also increases. So what are some other names for high energy? Remember the other names and synonyms for high energy?
Spin down.
Good. Because they're opposing static magnetic field. So spin down. And then there was also directionally another name. Parallel or anti-parallel? Anti-parallel. And then let's just review low energy. That's going to be your spin up, because they're going with the static magnetic field. So the energy gap increases at stronger field strengths. So fewer nuclei can oppose B sub 0. So more align, so that makes them more available to flip into the transverse plane. And as a result, we're always going to get more signal from our 3 Tesla magnet compared to our 1.5, just because we get a greater net magnetic vector to start with. So here's just an image of a brain scan. This coronal. Is this T1 or T2? T1, good. Fat's bright, fluid is dark. And you can see here that we were actually able to manipulate the parameters a little bit more too, and we still have higher signal. So at our 3 Tesla, our image, we have brighter fat. Our fluid is actually nulled a little bit more, which means we do have higher signal. And we were able to get higher signal, but our matrix size is even greater. And our next is less. So you can see here how radiologists really prefer 3 Tesla because we get better signal. We also get better resolution because we're able to manipulate those parameters. And our scan time has gone down because our next is lower. Our phase encoding direction's gone up, so we actually have more rows of K-space to fill, so that does increase our scan time a little bit. But you can see here how we get a better image at a less scan time. What are our drawbacks to our 3 Tesla? Yeah, obviously, anytime we have MRI, there's always that counterbalance.
Isn't there like a smaller bore?
Sometimes there's a smaller bore, so good. What else?
Tissue hernia or something?
Good, good. SAR. Our SAR levels increase because we're applying more energy into the patient. And then if we're worried about SAR, sometimes we can't put certain types of patients in our scanner. So sometimes we're limited on who we can actually scan with a 3 Tesla. So good. But generally, we're going to get better image quality on our higher strength magnets. And remember, at equilibrium, or also called thermal equilibrium, we're always going to get a slight increase in the number of spin ups compared to the number of spin downs. So as that gap between the energy spins increases, we get a larger net magnetic vector, which increases our B sub 0. Have more to flip into that transverse plane when we apply that first RF pulse. So when we have a low field strength, and when I'm thinking of low field, say I'm thinking like 0.3 or less, sometimes we have to do a lot of compensation to really get some good images. So this sometimes is requiring multiple NSA, number of signal averages, and remember that's part of the scan time, so longer scan time. larger voxels to get more of those hydrogen spins within that voxel, but up. Now our spatial resolution is going down. And then I talked about what are some drawbacks for these 3 Tesla magnets, and that's really just RF deposition, which increases our SAR and increases the likelihood of any type of burn. All right, proton density. So remember, this is an intrinsic parameter. This is something we cannot actually change on our scanner. But the reason the book mentions it is because certain areas of the body will have inherently less proton spins. And where are those areas of the body that have inherently less hydrogen spins or proton density? Or spin density. Good, the lungs. Yeah. So compare that to like your femur, where you have all the different types of tissue. You have fat, you have fluid, bone. All these have a lot of hydrogen protons within them. And you can see here we have 2 different voxels. This is an area of low proton density, or the lungs. So you're going to have less hydrogen spins and basically less signal to work with. And then high, you could just say any, just say brain. So you're going to get more signal from high proton density areas. So the reason they put this in the book is really to think about when you are scanning areas of low proton density like the lungs, sometimes you have to manipulate those extrinsic parameters to really boost your signal. So we are now kind of experimenting more and more with scanning the lungs. And we like to scan them on the 3 Tesla magnets, but if you are doing it on the 1.5 for like a pulmonary embolism, sometimes you really have to increase your next or your TR and things like that to get signal from those tissues. So this is just a review slide. We already talked about this. Areas of low proton density, lungs. High proton density really everywhere else in the body. Remember, this is something we cannot change. So since areas of low proton density have low signal, we might need to manipulate those parameters to boost that SNR. So here's an example of just basically increasing your voxel size. You can see here how we have these spins are all about the same size. So if you increase your voxel size, you're going to get more of those hydrogen spins. And really, those hydrogen spins are what's going to give us our signal. Because they're little bar magnets, remember? You add up those little bar magnets, it creates our net magnetic vector, and that's what gets flipped into the transverse axis. So which one of these boxes has less spatial resolution? The large, the one on the left. Good. All right, so we need to define voxel volume, and we also need to create some equations to calculate for not only voxel volume, but pixel size. So pixel is really the building block of our digital image, and you guys have talked about that in X-ray. And now we're dealing with voxels, and that's a unit of volume of patient tissue. So when we're dealing with MRI, you have your phase encoding direction, your frequency encoding direction, and then your slice thickness. Typically with your frequency encoding direction, is that the longer anatomy or the shorter axis of the anatomy? The longer axis of the anatomy. So the brightness of our pixel on our MR image represents the strength of our MR signal generated by that voxel. So our images usually come up in the 2-dimensional format, but what's really happening, it's really just a voxel that has been compressed down into a 2-dimensional image, or it's called a collapsed image. where you still have all three dimensions, but it gets collapsed down into a two-dimensional image. But you can, remember, you can flip through all those images, and you know that you already set like a certain slice thickness. But your voxel volume is determined by your pixel area times your slice thickness. Your pixel area is determined by your field of view, which sometimes on your GE scanner is going to be in units of centimeters, so be careful of that. And then on your Siemens unit, it's going to be in units of millimeters. So you have to convert everything to millimeters first. So on your GE unit, you just, what would you do? If it was 24 centimeters, how many millimeters is that? Which way do we move the decimal?
Right, yeah.
Right, so it'd be 240 millimeters. Okay, so just an easy conversion. Just multiply it by 10. So that was a little bit of a refresher.
Yeah.
And we always want to convert our field of view into millimeters because our matrix is always going to be in millimeters. So if your phase encoding direction happens to be 0.5 millimeters, that's what you are going to divide the field of view by. So pixel area, here's the equation, is field of view dimension divided by the matrix size. So you have to remember you always have a phase and frequency dimension. So you, whatever that field of view is, let's give it an example here. So imagine, like I said, the field of view was 24 centimeters or 240 millimeters. And then for this, this first example on the left, you have pixel dimension of 0.5. So divided by 0.5. And then you have to multiply that again. 240 divided by 0.5. That's going to give you your pixel area. A matrix always has a phase and frequency, so you have to do the equation twice. So if imagine your pixel dimension was 0.5 in the phase, but then your frequency was 1 millimeter. That's what the equation would look like. Okay.
And what is this in the equation again?
Pixel area. Yep. Pixel area is field of view divided by your matrix. And your matrix always has a phase and frequency value. And the frequency value is typically going to be your larger dimension.
Okay, I have a question.
Yeah.
On the formulas guide, it says that pixel size is this formula, and it has a different one for pixel area.
What's pixel area?
It says pixel area is multiplying phase pixel size by frequency pixel size.
Yeah. That's what we're doing right now. This is phase pixel size, and this is frequency pixel size.
Okay.
And I get what it means. Pixel dimension could just be 1, so you would only do the phase, and then you would do the frequency.
Okay.
But yeah, good. So but pixel area is when you multiply both.
Okay.
So if you had just one of those, that would be pixel size.
Yeah, but they would have to specify if that's the phase
Or frequency.
pixel or frequency. Yeah. But when you're solving these equations, because they might word it different, I don't want to get confused by getting too specific. They're usually looking for pixel area on like the registry. They want you to make the calculation twice.
And one is the frequency pixel size, and the other one is what? The 240 divided by 0.5.
So you'll have your phase pixel size times your frequency pixel size. And usually your frequency pixel size is going to be the larger dimension. So both times you're going to divide by 240 because that's your field of view. And that's not going to ever change. But remember, your matrix might be different. It's not always going to be an isotropic voxel. So you might have your frequency dimension a little bit larger than your phase. All right, so larger voxels are also called coarse matrix. This is where we have a low number of frequency encoding or phase encoding steps. So remember frequency encoding, that was really just how many times we look at that signal. So those raw data points along that signal amplitude, that's our phase frequency encoding. And then our phase encodings are the number of rows within k-space. So if we don't have, if a 128 by 128 would be considered a coarse matrix compared to a 512 by 512, which would be a fine matrix. So a coarse matrix, you're going to have larger pixels and voxels. So with a coarse matrix, since you have larger voxels, you're going to have more of those hydrogen spins within that voxel, so your signal is going to increase.
So your signal will be higher, but your spatial resolution will be lower?
Yes. And that's where we get that trade-off. And I gave you guys that Excel sheet. I know there's one online that's already filled out. But if you guys want to fill that out as we go, this is a good point to kind of fill that out as we go. So let me look at the ones that we should already have an answer to are the first 6, basically. So as we increase the strength of our magnet, go from 1.5 to 3 Tesla, what happens to our signal? Increases. You could say it's very proportional. It doubles. Same with our net magnetic vector, because as we have a stronger magnet, our net magnetic vector also gets larger, so our signal increases. If we're scanning areas of high proton density, what happens to our signal? High proton density. Signal increases because we have more hydrogen spins within that voxel. And then areas of low proton density, that's our lungs. Our signal is low to start with. And the next one are basically the same. The next two. Voxel volume increases. That really is associated with a coarse matrix. So what happens to our signal? Yes, good. On both of those. Good. So when we have a fine matrix, we have a high number of frequency encoding steps. So we're sampling the signal. We have more raw data points in the frequency direction. And then we have more rows in the phase direction. So our matrix is larger. So if you see that on a test, a large matrix equals a fine matrix. So our pixels are going to be smaller. If you see large matrix, it doesn't mean large voxel. Large voxel is associated with coarse matrix. So fine matrix, you could say, is associated with smaller voxel.
So would the signal be less then?
Perfect. Because you have less of those nuclei spins within them.
But higher spatial.
Higher spatial. Good. Yeah.
Fine and large matrix are synonymous.
Yes.
Large matrix, small voxel.
Large matrix, small voxel. Just don't get that confused with large matrix equals large voxel. Okay? So that's where the registry is going to try and confuse you, Got to be careful with how they word it. So that gives us our next one on our chart here. Fine matrix, our signal goes down. All right, so our SNR is proportional to voxel volume, and any parameter that alters the size of the voxel changes our SNR. And this is going to be a direct relationship. So if we increase our voxel volume, our signal increases as well. So if we double our voxel volume, we're going to double our signal. Take that last sentence I just said. With the doubling thing. So you always have to think about it in 2 dimensions. Because remember, our voxel is broken down in your phase and frequency. So if we increase our field of view, it's going to have the largest impact on our signal. So if when in doubt, you don't have enough signal, increase your field of view. Because that's going to not only double our signal, it's going to quadruple our signal. Because we have to, we're doubling it in both the phase and the frequency direction. So if we only doubled it in the phase direction, we would only double our signal. But if we double it in both dimensions, and that's usually our field of view is of both dimensions, we're going to quadruple our signal. But if we reduce our field of view by half, we're going to quarter our signal. So that's why they say field of view is the largest, has the largest impact on our signal. Because you're not going to get another parameter that quadruples or quarters it. Most of the time it's going to be double. So on that next line where I say field of view increases, why don't we put off right beside that, why don't we say if we increase our field of view by 2 times 2, and then over in SNR, we increase our signal by what?
4.
By 4. Perfect. So we have to be a little more specific when we talk about field of view. And that goes along with this line right here, Lily. Doubling the field of view results in an increase in SNR by 4. Okay. So here's 2 sagittal images of the brain. And you can see one done at 240 and then one done at 120. So if we had to say which one has higher SNR? 240, good. And then this one right here where our field of view has been halved, what's our signal? 4. Divided by 4, exactly. So you can see how it's starting to look a little grainier, right? We don't have as much signal from those tissues. And then we also have to worry about another thing, what we call phase oversampling, because we don't want the front of the brain and the back of the brain to wrap into our image. Because remember, we are exciting the entire brain with our head coil, so those tissues sometimes get mismapped into our field of view. So we would actually have to increase our phase oversampling as well. And that increases our scan time too. But we get smaller field of views for better resolution and to image certain areas of the brain sometimes. So if we're really just kind of narrowing down on the pituitary gland, we would want a smaller field of view because we want better resolution. But we just have to be conscious of what it does to our signal. You have your imaging matrix. This equates to the number of pixels in an image. Number of pixels present in the frequency direction is determined by the long axis of the anatomy. And the number of phase pixels determined by the short axis of the anatomy. So this is an inverse relationship. So as we increase our matrix or have a larger matrix, our signal is going to decrease. Inverse relationship. So see how they say imaging matrix that's associated with the number of pixels. But when we talk about voxels, we have to incorporate that last dimension, that slice thickness. And as we increase our slice thickness, our resolution goes down, but we're able to get more of those hydrogen spins within that voxel. So once again, this is directly proportional. So if we double our slice thickness, we're going to double our signal.
Question.
Yep.
So for voxel volume, so the larger the voxel, the more signal you get, correct?
Yes. All right, so we have an equation for pixel size or pixel area, but now we need an equation for voxel volume. So it's basically what we've calculated before. That 240 divided by 0.5 times 240 divided by 1. Now we have to factor in our slice thickness. So we multiply those two numbers times slice thickness. So that will give us all three dimensions, and that will be your voxel volume. So if you only have one side, your answer is going to be in units of millimeters. If you had phase and frequency, your answer is going to be in millimeters squared. Your voxel volume is always going to be in units of millimeters cubed. There are three dimensions. So voxel volume should always be in millimeters.
It's millimeters, right?
Thanks. Good catch. That's another place the register is going to trip you up. They're going to give you an equation for voxel volume, and you did all the math, you did everything right, and then you just chose the wrong one that said millimeters squared compared to millimeters cubed. Okay, so it's not necessarily wrong, but it's not the best answer.
Yeah.
So, just I'm telling you, just be careful when you read these questions. I mean, even on my tests, I try and trip you up just to get you used to kind of being. And they're not trying to trick you. It's not like the GRE. Has anybody taken the GRE? The GRE is trying to trick you. And that's just, I feel like it's evil. The registry just wants you to answer the best, give you the best answer. And that's the same with the X-ray registry. There's a couple right answers, but which one's the best answer?
I know,
Yeah.
like,
It's like, why are you trying to trip me up?
All right, so let's do an example here. So our field of view is 20 centimeters. Remember, on a GE scanner, it's usually going to be in centimeters. Our matrix is 256 by 192. Which one's the phase? Which one's the frequency? Good. Awesome. 256 is our frequency encoding direction. 192 is our phase. 20 centimeters equals how many millimeters? Good. And then our slice thickness should be in millimeters. once again, everything should be in millimeters. So now that we've done all the conversions, so to get the pixel area, it's 200 divided by 256 times 200 divided by 192. Go ahead and get that number first, and then multiply that by 4 millimeters. So your answer should be 3.24 millimeters cubed. So the trade-off for voxel volume, so as we increase voxel volume, it does increase our signal, but it will result in less spatial resolution. And the drawback there is what we call partial volume artifact. So say you do have pathology, but it's smaller than the voxel size. What happens is all that signal within that one voxel gets averaged together, and sometimes a radiologist is not actually able to determine there is a pathology. So as your voxels get smaller and smaller, you're able to delineate that pathology a lot better. So partial volume artifact just means that we have voxels that are too large and we might miss a pathology because our signal's getting averaged together. So we never really want any partial volume artifacts. Radiologists sometimes say that in the report. It could be something there, but due to partial volume, I'm not able to make an accurate assessment. All right. Then you have your TR, your TE, and your flip angle. These are considered parameters that influence contrast. Because remember, these are things that are really part of our pulse sequence. And our pulse sequence determines what type of weighting we're working with. But it also influences our SNR and image quality. The next line I say, spin echo pulse sequences generally create more signal than our gradient echo pulse sequences. Do you guys remember why that is? We're lacking one thing in our gradient echo pulse sequence that is detrimental to our signal. What was that one thing? Remember I showed you quickly at the end of the last lecture, I had two pulse sequence diagrams. And there was one thing we were missing on our gradient echo pulse sequence.
The 180.
Perfect. It doesn't have that 180-degree refocusing pulse. So you could say GE lacks 180-degree refocusing pulse. So that refocusing pulse, the main objective of that is to really regrow that signal. And our spin echo pulse sequences have that. And sometimes they have that multiple times with, like Nick was asked, with that turbo spin echo, where we have multiple 180s. So we're regrowing that signal over the course of time. So you get, I guess you could say that turbo spin echo really does increase our signal. But the main reason we use it is to speed up our pulse sequence. So the gradients actually refocus the signal in a gradient echo pulse sequence, but they don't do it as efficiently. So our signal doesn't regrow as high. All right, TR. Once again, it's part of the scan time equation. But T1 recovery, the main parameter that influences T1 recovery is our TR. So if we have a longer TR, we're allowing that tissue to recover more. So if we have a larger net magnetic vector before the next RF pulse, we're going to have a larger vector, and then it'll get flipped down, we'll have more signal. So if it regrows more, larger vector to get flipped into the transverse plane. But if it only regrows a little bit because our TR is short, we have a smaller vector that gets flipped into the transverse plane. So longer TR, more recovery of the longitudinal magnetization, which is available to be flipped into the transverse plane on the next repetition. So increased TR, increased signal. Direct relationship. So I have 3 images here where you have your TR steadily increasing. So you can see here we have a low TR and a low TE. So that's associated with a T1 weighted image. But those aren't really within the ranges that we want. Remember, we want at least 300 to 700 for T1 weighted. So it's a little low on our TR. And you can see, if you blew this up a little bit, how you have a very grainy image. Almost like a comparison for X-ray would be like quantum model. Just a very grainy image. But then as your TR increases, you can see the TE never changed, but your TR is now 500, and we get a T1 pulse weighted image. And then as we increase our TR even more, we're starting to get what looks like a proton density weighted image. But you can see how all these tissues within the brain start to get brighter and brighter, right? Your white and gray matter are increasing in signal. And then even the fluid starts to increase in signal. So your signal is going up as your TR goes up. Okay? So let's stop there. And we'll take a break and we'll start going over procedures. Any questions? You guys okay?